So I'm going to talk to you about calcified lesions. Thanks very much. Whether we should pop them, cut them, shave them, shock them, or blast them. And I'm going to summarize really, I think, what is the state of the art for calcified lesions. So here's the problem, right? You can't deliver gear across calcified lesions. If you do, you can delaminate the polymer that alters the drug elution kinetics. And probably the worst thing that can happen is actually to get the stent in and deploy it in a heavily calcified segment, which then can't expand. In an analysis of over 13,500 patients, of basically all the patients that we had in any randomized controlled trial at CRF over the span of 8 years, we found that moderate to severe calcium had a significant hazard, and not even just severe, but moderate to severe had a significant hazard of target lesion failure, target vessel failure. Let's go through some fundamentals, because the fundamentals are critical. Remember that angiographically severe calcification is calcium on both sides of the artery wall within the lesion without movement of the angiogram. And if you have angiographic calcification on either side of the lesion, which is only present during fluoroscopic movement, that's moderate. This is a study of 440 patients who all had angiography, IVUS, and OCT. We learned a lot from this study. So you can pick up calcification in almost every patient. Okay, microcalcification, macrocalcification, about 80%. Interestingly and surprisingly, the OCT detects it a little bit less than the IVUS. And remember, the reason is we have far field with IVUS, as Darshan taught us yesterday, but the OCT gives us near field, and when we have lipid in front of calcium, we get a signal attenuation and we can't see both deep calcification as well as calcium that's obscured by luminal lipid. But interestingly, only in 40% of cases were we able to identify calcification on the angiogram. So why is that important? It's important because the angiogram is the gatekeeper. And the reason the angiogram is the gatekeeper is because only angiographic severe calcification predicts stent under expansion. Now, you can see we didn't check moderate to severe in this study, and so likely moderate to severe is the line at which we have to draw threshold in order to think about our advanced lesion preparation. So fundamentals, angiographically invisible calcification doesn't impact stent expansion. There's one exception to that, of course. That's a calcified nodule. And then severe angiographic calcification does, moderate to severe calcification probably does, and calcified nodules are the exception. On IVUS, more than 270 degrees is severe. On one cross-section, 180 to 270 is moderate. And what you can see is that the IVUS is not very sensitive compared to the angiogram, but it's very specific, right? So you pick up a lot of these. Now, what you'll notice here is that you start to identify calcium on the angio when it gets to 110 degrees of arc on IVUS. So compared to IVUS, angio has poor sensitivity, but very high specificity. We made a very simple calcium algorithm for you, okay? And the way to remember it is the mnemonic calcium laden. If the calcium is circumferential, you get a point. If the length of the calcium with the arc of the calcium is 5 millimeters and 270 degrees, you get a point. If the diameter adjacent to the calcium is less than 3.5, you get a point. And you all know this is Laplace's law, right? If you have a big vessel, you're most likely to crack this with an NC balloon. And nodular calcification gets a point. And if you have greater than equal to 2, you need to think of advanced lesion preparation. So this is the IVUS St. Francis scoring system. So we know that in the presence of moderate to severe calcification, IVUS can help us, and sound penetrates through does not penetrate through calcium, so we get arc, but we don't get thickness. I don't need to show you about OCT calcification. I think you've seen this with Julio, with me, and with lots of other speakers. Same cross-sectional metrics, 270 degrees for severe, 180 to 270 for moderate. Again, you'll notice that the predictors of angiographic calcification are relevant. 101 degrees, 4 millimeters, and 0.57, and those correlate beautifully with our St. Francis angiographic calcification score, which is a rule of 5s, 5 millimeters long, 0.5 centimeters thick, and 50% of the arc. Now, we know OCT can penetrate calcium because Calcium is a crystal, and light will go through a crystal. And we know that sound cannot penetrate through a crystal because it reflects off of it. So what that does is allow us to see the thickness of the calcification. And just like we have an IVUS score, we made a very simple OCT score, which I just mentioned to you, which tells you when to think about advanced lesion preparation. Okay? It doesn't mean you have to ROTA or IVL. You need to think that when you have 50% of the arc, 0.5 millimeters of thickness, and 5 millimeters long, you need to think about advanced lesion preparation. So moderate to severe angiographic calcification, OCT can aid in determining the lesion preparation strategy. Light can penetrate through the calcium, so we get arc, length, and thickness. Now, how do we treat it? Now, one way is that we need to cross the lesion, right? So that's the goal of therapy. And the second is to modify the lesion. And we can modify it by debulking, by inducing calcium fracture. And ultimately, what we want to do is get a big space, right? How do we do this? Well, the way we do this is balloon-based strategies. We've got non-compliant balloons. We've got scoring balloons, cutting balloons, compartmental balloons, ultra-high pressure, all with very, very little evidence, okay? We are using these based on anecdote and somewhat conjecture. Non-balloon-based strategies include laser, rotational, orbital, and intravascular lithotripsy. As you know, most of the studies for this have unfortunately failed. What do? If you do atherectomy, particularly rotational atherectomy, which has the evidence, you get an easier procedure. You have greater technical and procedural success and less crossover. But again, the evidence for this is relatively lacking. Here's the algorithm, okay? The algorithm starts with the angio. It has to. If you don't have moderate to severe calcification or greater, you're going to be fine, okay? Unless it's a nodule. And then use OCT or IVUS to help you determine which strategy. If it's deep or medial, we have different strategies. IVL and laser are going to be better. Superficial, we've got lots of choices. Rotational, orbital, IVL, and ALCA. And nodular, for crossing, we want orbital or rotational atherectomy, but for cracking the nodule, actually IVL is highly effective. So, most superficial calcium visualized by contemporary intravascular imaging is superficial, particularly with OCT, as I showed you the numbers. All calcium visualized by contemporary OCT is superficial. Superficial calcium on OCT should really be defined in only two ways: thin cap or thick cap, because it directly impacts treatment strategy. Here's an example of a run. And while we talk about nodular calcification and eccentric and concentric, the reality is one lesion has all different types of calcium. So we need to think about how we're going to modify all of these sections. So the morphologies are very easily distinguished by OCT. It's harder by IVUS, okay? You can't see quite as well. You cannot see details. You can't get thickness. So you really have to study very closely the angiogram with the IVUS in conjunction. You need to be able to recognize a calcium fracture because this is the goal of therapy. You can see that calcium fracture is easily identified by OCT. On IVUS, it's a discontinuity of the linear opacity that's in the vessel wall where you get a reverberation signal behind it. So why do I say some of the things that I did? What about deep or medial calcification? Look what happens if you try to do atherectomy in a thick cap superficial calcium. You basically just drill off the pillow and you're left with a completely unmodified segment of calcification, right? So atherectomy techniques do not work for thick cap calcium. What works? IVL. Why? You squeeze the pillow to the point at which it's squashed down, you reduce the impedance, and the IVL enters the calcium directly and fractures it. What else can we do? We can do laser because it does the same thing. Laser actually will penetrate through the pillow and actually give the highest impedance, particularly when we do a contrast injection, as you know. The mechanism of fracture of calcification by laser is exactly the same as IVL. It is an acoustic pressure which is converted into mechanical energy. For superficial, we got lots of choices. Eccentric calcification behaves differently because when you inflate a balloon on calcium that's less than 180 degrees, there's only one mechanism for expansion, and that is to tear the interface between the fibrous tissue and the calcification. The atherectomy mechanism of action is wire bias dependent. When we load into a wire, we're able to modify the calcium. Here's an example of calcium-dependent lesion preparation where you can see that thinning the calcium, getting it to less than 0.5 millimeter allows us to fracture it. Wire bias-dependent lesion preparation is very, very relevant. Look at this example where we have heavy wire bias and we've basically cut a hole into the artery. And so as a result, we have a contained perforation. Nodular calcification, we need to pay careful attention. Look at this example of pre-rota and post-rota. What's the problem here? The problem here is this, is that the wire is biasing away from the nodule and you can see it's completely unprepared. But when we think and use the imaging to our advantage, you can see that orbital atherectomy actually cuts this nodule off and then we can get adequate stent expansion. So in summary and conclusion, the key take-home message is the angiogram is still the gatekeeper. You need at least moderate to severe calcification to start to think about advanced lesion preparation. When you've got angiographic severe calcification, using an algorithmic approach and integrating intravascular imaging can be very helpful. What device you're going to use is really very much dependent upon the findings of the intravascular imaging, and you should be using intravascular imaging also to optimize. Calcium fracture or nodular debulking should be identified before we put DES in. Thank you very much.